Thank you. Okay. Good morning, everyone, and welcome. I'm happy to be here to discuss sickle cell disease. September is actually National Sickle Cell Awareness Month, so the timing of this presentation is perfect. Okay, so let's get started. So I'm hoping after this presentation, you'll have a better understanding of what sickle cell disease is. I'll review the pathophysiology behind sickle cell disease, and I'll specifically review the more common complications you'll see our pediatric patients present to hospital with, and then review the treatment and management for these complications. So what is sickle cell disease? It is an inherited red blood cell disorder that is autosomal recessive. It's the most common inherited severe blood disorder in Canada. There's an increased incidence in the African Canadian population, about 1 in 10. We also know that people of Middle Eastern, Asian, Indian, or even Mediterranean descent can be affected by sickle cell disease. It is a broad definition of a group of disorders with the clinical features related to the hemoglobin S mutation. Homozygous SS is the most common type of sickle cell disease, but we also have compound heterozygous SC, S beta plus thalassemia, S beta zero thalassemia, SD, and SE. So how do you inherit sickle cell disease? So from this diagram, you can see that both parents carry the sickle cell trait. Sickle cell trait is denoted as AS, A being normal hemoglobin, S being sickle hemoglobin. We know that each time this couple has a pregnancy together, there are 4 possibilities. So there'll always be a 25% chance of having a child that has normal hemoglobin, which is denoted by AA, or the picture to the very bottom left. There's always a 50% chance of having a child like themselves who carry the sickle cell trait, which is AS, and then a 25% chance with every pregnancy of having a child with sickle cell disease. And in this case, this child specifically has homozygous SS. So how do we test for sickle cell disease? One way is through newborn screening. So sickle cell disease was added to Ontario newborn screening in November of 2006. Since then, all babies are now screened for sickle cell disease. If the screen comes back positive, this is reported back to families by about 2 weeks of age. Ontario newborn screening allows us to help with early detection and also to help prevent morbidity and mortality. At Sick Kids, we get about 60 new patients per year through Ontario newborn screening. This also helps us to not only see the families early, but to educate them about the early signs and symptoms to look out for, and then to offer genetic counseling to help hopefully prevent future sickle cell pregnancies. A few other ways that you can test for sickle cell disease. One is the sickle dex test. It's a pretty common test. It's really just looking for sickle within the blood. So for our patient who is AA, it would come back negative. But for our parents who are a trait and our patient who has actual SS, it'll come back positive. So it's not the best test to actually determine if someone has disease or trait. It really just detects the sickle within the blood. The second test is a hemoglobin electrophoresis, and this looks at the different percentage of the different types of hemoglobin in the blood. So for our parents who are sickle traits, their results would come back about 30 to 50% A hemoglobin and about 30 to 50% sickled hemoglobin. Compared to our patient with SS, he would come back about 100% sickled hemoglobin. The next test would be DNA. You can't get these results back quickly. For us, we send them to the Hamilton McMaster DNA lab, and it takes about 6 to 8 weeks for those results to come back. So we know that sickle cell disease is a beta chain mutation that causes the substitution of valine for glutamic acid. The body produces red cells that are sickle-shaped when deoxygenated, and these sickled red cells are very sticky and very hard, and they don't flow very well through the blood vessels. The sickled red cell only lasts maybe 10 to 20 days, and it's quite fragile compared to a normal red cell, which lasts maybe 120 days. When you look at the CBC of a child with sickle cell disease, you'll automatically see a lower hemoglobin and a very high retic count. That retic count is quite high because the bone marrow is constantly trying to make new red cells because those sickled red cells don't last as long. We also know that sickled red cells are also chronically low in oxygen. So our sickle cell patients are at an increased risk to infection, specifically Streptococcus pneumoniae. And this is all related to spleen function. So we know the spleen is there to help fight infections and filter blood, but we also know with our patients producing red cells that are sickled shape, over time, these sickled red cells start to damage the major blood vessel leading to the spleen, causing intravascular sickling. And we know specifically in the SS group that they are considered asplenic by about 5 years of age. So one way we can help reduce the rate of infection in our sickle cell population is by putting them on penicillin prophylactically. So back in the 80s, there was a penicillin study. It was a multi-center randomized double-blind placebo-controlled trial. This study actually ended 8 months early because they saw 84% reduction in the incidence of infection in the penicillin group. So the penicillin group had 105 participants and they only saw 2 infections. Compared to the placebo group that had 110 participants, they actually saw 13 infections and 3 deaths. So since this study, all sickle cell patients are put on penicillin prophylactically shortly after diagnosis and kept on the antibiotic until at least 5 years of age. So here in Canada, we don't have penicillin suspension or liquid. We only have amoxicillin suspension. And so the dosing is based on age, not so much weight. And so shortly after birth, we will start our babies on amoxicillin at 62.5 milligrams twice a day from 2 months to 6 months, and then double the dose to 125 milligrams twice a day, and that will be from 6 months to 2 years, and then double it again from 250 milligrams from 2 years to 5 years. Another way to help prevent infection is through immunizations. So all of our patients should be following the normal childhood vaccine schedule that Ontario has laid out. We do add a few extra pneumococcal and meningococcal vaccines to the schedule, well, specifically Prevnar 13 and Pneumovax 23, but in the past month, these have now been updated to Prevnar 15 and Prevnar 20. And then the meningococcal vaccines specifically are to protect against the ACYW and B strains of meningitis. So before I go into some of the common complications with sickle cell disease, I just want to highlight the Ontario Health Sickle Cell Quality Statements. So in January of 2023, Ontario Health launched these new standards. They're quality statements that describe what high quality care looks like for people with sickle cell disease. So specifically for this presentation, I want to focus on quality statement 3 and 4. So quality statement number 3, vaso-occlusive acute pain episodes. People with sickle cell disease who present to an emergency department, or hospital with a vaso-occlusive acute pain episode receive a timely pain assessment and clinical assessment. Their treatment begins within 30 minutes of triage or 60 minutes of presentation. Before discharge, they are involved in the development of a plan for continuing to manage their acute pain episode at home. This plan includes a symptom management strategies and information on how to access follow-up care and support from healthcare providers as needed. Quality statement 4, life-threatening acute complications. People who present to an emergency department or hospital with a potentially life-threatening acute complication of sickle cell disease have their condition and its severity identified through a prompt clinical assessment. Their condition is managed appropriately with an individualized treatment and monitoring plan. And I just want to also review the medical directives that our RNs have in the emergency department, because this will also give you a better understanding of how we can implement specifically quality statement number 3. So the first medical directive is peripheral intravenous insertion. The indication for this is sickle cell anemia patients and chief complaint of fever. Acetaminophen indication is a first-line treatment of patients greater than 3 months of age presenting with a fever, or treatment of patients greater than 3 months of age presenting with mild, moderate, or severe pain. Ibuprofen, treatment of patients greater than 6 months of age presenting with fever, and then treatment of patients greater than 6 months of age presenting with mild, moderate, or severe pain, but not to be given for epigastric pain. Blood work, specifically peripheral blood cultures, CBC, diff, retic, sodium, potassium, creatinine, glucose, and insertion of a saline lock, indication for sickle cell anemia patients, and chief complaint of fever. So what is a fever? So in our population, a fever is anything greater than 38 degrees under the arm or greater than 38 degrees by mouth. We advise our families not to give Advil or Tylenol for fevers. We want them to present to the emergency department immediately. We've had cases in the past where families have given Advil or Tylenol at home. They present to a peripheral hospital. By the time they get there, the child doesn't have a fever. And then that hospital doesn't take the fever seriously because they don't have a documented fever and they don't think there's a reason to give antibiotics or do blood cultures. And we've had cases where families have been sent back home to continue to give Tylenol. And we've even actually had a few deaths because of this. So we specifically ask our families not to give anything, to present immediately so that the assessment can be started promptly. When it comes to fevers, vaccines are one exemption to the rule. We know vaccines can cause fevers and our population gets quite a bit of vaccines. That being said, if they get a vaccine and have a fever later that day, it still shouldn't be a high-grade fever and it still shouldn't last more than a day. So if they are still having fevers a day later after getting vaccines, they're still supposed to come to the emergency room. So all of our parents are given emergency room letters stating that the child has sickle cell disease, what a fever is, and why the assessment is needed urgently. Attached to it is the fever management guidelines that we use at Sick Kids for our sickle cell patients with a fever. So it clearly outlines what to do with a fever, what blood work, cultures, antibiotics. All of our patients who present to our emergency department with a fever are considered a CTAS 1 or 2. Anytime our patients are admitted to the emergency department, sometimes the emergency room will request a consult from our hematology fellow. If this is done, our hematology fellow will definitely contact us the next day in regards to that patient being seen in the emergency department. And then also for us at Sick Kids, we use the electronic system Epic. And so all of our patients have us listed as their care team members, and we are alerted of any admission or blood work that has been done on them. So fevers. So they need to be seen promptly. We'd like to get IV antibiotics into them within 60 minutes of presentation. Our go-to antibiotic for sickle cell patients with fevers is ceftriaxone at 100 milligrams per kilo per dose. If they're allergic to ceftriaxone, they can get levofloxacin at 10 milligrams per kilo per dose. Once that fever is documented, then by all means, give a dose of either ibuprofen or acetaminophen to bring that fever down. We always encourage oral fluids, but for sure, if that patient's looking a bit dehydrated, we'd give a normal saline bolus. And if they're totally not tolerating fluids, then we would start some kind of fluids at maintenance. So when do we admit a patient with fever? So there's quite a few different types of criteria to think about. So one would be if they're ill appearing or looking toxic, if they've had previous episodes of severe sepsis or meningitis, any signs of respiratory distress, changes on chest x-ray or blood work, if they've had poor compliance with their antibiotic prophylaxis, if they've missed clinic appointments or they've had missed or delayed immunizations, that's also a reason to admit them. And another reason would be if this is 2 or more emergency room return visits for the same episode of fever. So when it comes to admitting our patients, we have a few options. So if that patient lives within the catchment area of our 2 satellite clinics, so we have one in the West End in Brampton, one in the East End at Scarborough Centenary, we can always reach out to them to see if we can transfer a patient. If not, we're happy to admit them at our hospital at Sick Kids under the general pediatric floor. Depending on how ill that patient looks, the hematology fellow would be involved with that admission. When it comes to outpatient management, if the patient is looking really well in the emergency department, if they've at least had 2 to 4 hours of good observation in the emergency department, their vitals are stable, they're able to tolerate oral fluids and medication, then for sure they can be discharged home on antibiotics. And so we want to ensure that they have at least 1 day supply of outpatient antibiotics. So when they first arrived to the emergency department, they got that first dose of IV ceftriaxone, which lasts about 24 hours. We know that blood culture results take about 48 hours to come back. So if we are discharging them home, we want to give them at least an extra day of antibiotics until those results come back. I know for our emergency room, for some of our patients who present in the middle of the night, our emergency room actually stocks oral cefuroxime so that they can hand 2 doses to the family so that they at least have that 1 day supply of antibiotics. And then to always arrange close follow-up, especially for the babies under 12 months of age, if you don't have a clear focus for their fever. So pain. Sickle cell pain is another common reason our patients present to the emergency room or need hospitalization. This is any decrease in arterial oxygen tension causing red cells to sickle. This can lead to intense pain due to diminished perfusion. These sickled cells adhere to each other, causing obstruction in the blood flow. Pain can be in the bones, the chest, or any other part of the body. Pain can be mild to severe and can last hours to days. The triggers for pain can be different for each patient. Some examples of triggers are stress, weather, dehydration, or even overexertion. You can tell from the picture on the left, to the very left, there's normal red cells that are nice and round and donut shaped, and they flow very well through the blood vessels. Compared to our sickled red cells on the right, they all start off nice and round, but the minute they're deoxygenated, they change into that sickled shape and stay that way. And then they can sometimes start to clump together, blocking blood flow in the smaller blood vessels. So how do we educate about pain? So it's something that we review with our families a lot during their clinic visit. We talk a lot about something called the 3 Ps. So the 3 Ps include pharmacological, physical, and psychological approaches. So our pharmacological go-to medications are acetaminophen every 4 hours, ibuprofen every 6 hours, and then either morphine or hydromorphone every 4 to 6 hours. Physical would be anything to help increase circulation, so heat, massage, movement. Psychological, anything to try and take your mind off the pain. So imagery, relaxation, distraction. So whether that's watching a movie, listening to music. The combination of the 3 Ps helps to manage pain, but you have to remember it doesn't stop the actual sickling. So how can I keep my patient comfortable until the sickling episode actually stops? We review a lot about how to use pain scales with our parents. So depending on the patient's age, it could be the FACES scale versus the numeric scale. With the amount of narcotics that we give for sickle pain, patients should be taking PEG daily to prevent constipation. We're always emphasizing hydration even when the patients are well, because simple dehydration can cause you to sickle a bit more. For our emergency departments, they do expect our patients to try some kind of oral pain management at home before presenting to the emergency department. So if things are not working out at home and the pain's just not manageable, then for sure they're coming to the emergency room. You want to start with your initial assessment. So again, assessing and documenting the pain scales and scores, confirming with the parents what analgesics were given when and the timing of them, a full set of vitals and monitoring. You want to make sure that our patients are oxygenating and satting well. Majority of our patients that come in for straightforward pain will most likely get a CBC diff and retic done on them. If they have not started any medication at home, then for sure we start everything orally. So the ibuprofen and acetaminophen can be started. So ibuprofen at 10 milligrams per kilo per dose and acetaminophen at 15 milligrams per kilo per dose, and emphasizing oral hydration. If, say, they present to the emergency room and they've done, say, both ibuprofen and acetaminophen, and they've either run out of morphine or they've never had morphine, then for sure we would like to give these medications within 60 minutes of presentation. And so the morphine oral dose is at 0.3 to 0.5 milligrams per kilo per dose. And hydromorphone is more based on weight. So if they're less than 50 kilos, the dose could be 0.08 milligrams per kilo per dose. And if they're over 50 kilograms, it could be 2 to 4 milligrams per dose. So after reassessment, so say you've tried all of the oral routes, have given all of the medications, that's when you start to think about needing that IV to give an IV bolus. For some of our patients, they come in with trying everything already. They're in excruciating pain, and you kind of automatically jump to the IV route. For some of our patients, we will give intranasal fentanyl to help calm them down and get the IV started. So on top of the intranasal fentanyl, once you get that IV in, we could do a morphine IV dose at 0.1 milligrams per kilo per dose, or hydromorphone at 0.02 milligrams per kilo per dose. Once you've given those medications to kind of work, if they are not working, then for sure you're thinking about admitting that patient and starting some kind of infusion. So our emergency room will contact the general pediatrics team or try to arrange transfer. But while they're waiting, they will start a morphine infusion at 40 mics or a hydromorphone infusion at 8 mics per kilo per hour. So once our patients are admitted, for us at Sick Kids, anything that started in the emergency department is a continuation to the general pediatric floor. So those infusions will continue and be handed over. Our team is notified also by the pediatric ward or through Epic about that admission. So medication management for inpatients, again, the infusion would be continued, and then we also continue around the clock ibuprofen at every 6 hours and acetaminophen at every 4 hours. If our team is finding that the pain is not improving within 24 hours after admission, we will ask the acute pain service team to be consulted. And so this acute pain service team can start patient-controlled analgesia. Sometimes they start ketamine and fentanyl infusions. They will come in and check in with our patients daily to see how their pain is improving or not. And then they'll also manage some of the side effects from all of these narcotics. So like itchiness, nausea, or vomiting, they'll also prescribe those medications as well. As the days go on, you're hoping that their pain gets a little bit better and you start to get to the point that you're going to now start weaning all of those infusions. And eventually you want to get down to the oral equivalent of those infusions. Throughout the admission, obviously keeping a close eye on all vitals, especially being on all these different types of narcotics. You still want to think of your 3 Ps. So definitely we have child life at Sick Kids. So sometimes we involve them for distraction or even for different procedures or IV starts if the IV has fallen out. And then physiotherapy. This is probably the most important part about inpatient admission for sickle cell patients with pain. So with our patients, they're obviously in excruciating pain. There are times when they are laying still or lying flat in bed for days because the pain is so bad. They're not sitting up, they're not moving around, they're not taking deep breaths and moving air in and out of their lungs. We have an automatic referral to physiotherapy to get incentive spirometry started. And incentive spirometry is usually done on an hourly basis. And the reason for this is that with them not moving enough air in and out of their lungs from these pain crises, it can actually turn or throw themselves into something called an acute chest crisis. So we definitely want to avoid that. So when it comes to just even basic pain management, incentive spirometry is something that's super important to help prevent our patients from becoming even sicker. Fluid should always be kept at maintenance. You don't want to overdo it with the fluids. You definitely want to prevent any pulmonary edema. And then again, using PEG to help prevent constipation from the amount of narcotics that they could be on. So once we get to the point of being discharged home, this also goes back to quality statement number 3 about having a plan in place at discharge. So this is a discharge plan that we use with our families. It again reviews the 3 Ps, but specifically we're looking at the pain ladder. And so this pain ladder can either go up or down. So you start with mild pain, which is a scale score of about 0 to 3. You can use either acetaminophen or ibuprofen. If the pain is moderate or you have a pain scale of about 4 to 6, you can use acetaminophen and ibuprofen and then morphine or hydromorphone PRN. If the pain is severe on a scale of 7 to 10, you can use all three medications. So acetaminophen, ibuprofen, and then either morphine or hydromorphone. We don't expect all of our patients who are admitted in pain to go home pain-free. So sometimes you get to the point that you're taking all oral medications, and families can kind of manage this at home on their own. This is where this pain plan comes into place, because we can review it with them before discharge about the medications they're on, the dosing, the frequency, and when the last dose was given and when the next dose is due. Having a pictorial like this too, we kind of we tell our families to keep this picture on the fridge too, because the pain ladder could also be used for future pain episodes. So really just having a plan in place at discharge, knowing that not all patients go home pain-free, so they might need something like this to follow. Still emphasizing hydration, because again, simple dehydration can cause sickling. And then to really reinforce the monitoring of fevers. So being on all of these medications can mask a fever. There are times where we have patients come in for fever alone, pain alone, and then sometimes they follow each other. So just really making sure that they're checking temperatures before they give these medications. And if they have any brand new fevers, then for sure that's a reason to represent to the emergency department. Okay, so before I go on to the next few complications, I just want to review blood transfusions because the next few complications will involve the need for a blood transfusion. So sickle cell patients are at risk for red cell alloimmunization. Alloimmunization is an immune response to foreign antigens after exposure to genetically different cells. Approximately 30% of transfused sickle cell patients compared to 2 to 5% of all transfusion recipients. The reason being is that red blood cell antigen expression is higher among the sickle cell population due to the mostly Caucasian donor pool of blood. One way to help prevent this is by doing extended antigen matching for our patients who have had one or more alloantibodies from transfusions. So when do we transfuse? So super important to know what your patient's baseline hemoglobin is. Anytime there's a drop in hemoglobin, anywhere from 10 to 20 grams below baseline, and they are symptomatic with their anemia, so increasing oxygen requirements, increasing respiratory symptoms, tachycardic, looking more pale, more weak, complaints of headaches, those could all be reasons for needing to transfuse a sickle cell patient. Is your transfusion needed for an acute basis versus a chronic need? And we want to ensure that anytime blood is given to our sickle cell patients, that it's free of sickled hemoglobin. So sickle cell trait carriers can donate blood, but when our sickle cell patients actually need blood, we want to give them nothing but AA blood. At the same time, we still want to encourage our families to donate blood because just in general, there's a need for blood transfusions. So simple transfusions. This is used for an acute drop in anemia. It helps with the increasing oxygen carrying capacity. Packed red blood cell transfusions are usually anywhere from 10 to 15 mils per kilo. It takes approximately 4 hours to complete. Again, giving nothing but normal AA blood helps to lower the amount of sickled hemoglobin within the system. And sometimes for some of our patients after repeated transfusions, there can be an increase in iron overload and sometimes a need for iron chelation therapy. So exchange transfusion, this is used to help reduce the percentage of infected or diseased cells, and in this case, decrease the amount of hemoglobin S. It also helps to increase oxygen carrying capacity and stops the sickling process. And it also helps to reduce blood viscosity. Exchange transfusions are mostly used for severe acute chest syndrome and stroke. The way exchange transfusions are done is usually through an automated apheresis machine. For our patients who get this done at Sick Kids, it's definitely done in the ICU setting where they'll have a femoral line inserted. Exchange transfusions require more blood than a simple transfusion, which ultimately means more donor blood and a higher increased risk of alloimmunization. Exchange transfusions are a lot shorter than simple transfusions. They only last about 1.5 to 2 hours. This is an example of what an exchange transfusion would look like. So you're bleeding off about 500 cc's of blood and then infusing 500 cc's of saline. You bleed off another 500 cc's of blood and then infuse 2 units of packed red cells. And then you repeat these 2 steps until the desired volume is achieved. Sorry. So splenic sequestration. So again, the spleen is there to help filter blood. This happens when this blood gets trapped in the spleen. So all this blood rushes in to get filtered. The exit gets blocked by those sickled red cells, and it starts to enlarge the spleen because blood is now trapped in there. Since the blood can't get out to circulate to the rest of the body, we'll have a drop in hemoglobin, so the patient will look anemic. They'll also have mild to moderate thrombocytopenia. They will clinically look unwell, looking more weak, more pale, more tacky, more irritable. They'll have a palpable spleen. Some of the older kids can say that they have left-sided abdominal pain. Some of our splenic sequestrations can progress to shock and death. We know that the mortality rate is anywhere from 12 to 20%. For some of our patients who have presented to emergency, their hemoglobin they have been as low as the 20s. Splenic sequestration, we know if it happens once, it can happen again. And so one way to unblock the spleen is by giving a simple blood transfusion. And so remembering that the spleen still is holding on to some blood, we want to give a small transfusion, about 5 mils per kilo, because once that spleen is unblocked, all that blood is still released with the 5 mils per kilo that we just gave. So you don't want to give too much blood in this case because you don't want to increase the viscosity or increase the patient's hemoglobin too much. All of these patients will be referred to general surgery to have a discussion about having a splenectomy and removing the spleen. So through newborn screening, one of the education pieces that we teach parents is actually how to palpate the spleen and what the early signs and symptoms of anemia are. I think it's important to remember that when you also see sickle cell patients with fever, whether it's viral or bacterial, sometimes the spleen can be triggered by those infections. So always double checking your spleen and feeling for it. So acute chest syndrome. By definition, it's a radiological appearance of a new pulmonary infiltrate of at least one complete lung segment with respiratory symptoms. It's often hard to distinguish from pneumonia. It's the second most common reason for hospitalization, and it's responsible for about 25% of deaths with children with sickle cell disease. Acute chest can be mild, moderate, or severe. So some of the symptoms of acute chest, so fever, chest pain, coughing, wheezing, hypoxemia, tachypnea, and definitely changes on chest x-ray. So what causes acute chest? So one of the reasons could be plain old sickling in the lungs, so pulmonary infarction. The second could be infection. So this is the most common reason we see our patients admitted for acute chest syndrome. So whether that's bacterial versus viral. So always having that blood culture done, right? And then thinking of maybe even doing an NP pharyngeal swab just to kind of rule out any other viruses. And then bone marrow necrosis, it's not as common, but I would say every year we see a handful of kids present this way. So this is quite a severe form of acute chest. So it is associated with vaso-occlusive pain, mostly of the long bones. A lot of the patients report it being the worst pain ever. So these patients usually already are admitted, already have acute pain services involved. Acute pain services has probably already, done everything that they can when it comes to pain management, but yet these kids are still saying it's that 9, 10 out of 10 type of pain. We know that the bone marrow contains a high fat content. And so what happens in bone marrow necrosis is that fat is released into the bloodstream and can travel to the lungs. So this leads to pulmonary hypertension or severe lung inflammation and hypoxemia. On blood work, we'll see an increase in the nucleated red blood cell count. Again, these patients are quite severe respiratory-wise, and for sure are already being admitted into the ICU setting for not only respiratory support, but an exchange transfusion and insertion of that femoral line. So how do you treat acute chest syndrome? So again, they're probably already admitted. They will be on antibiotics as indicated. Again, you're going to want to help with hydration, but again, keeping your fluids at maintenance. Analgesics for any type of pain, antipyretics to treat your fever, and then bronchodilators if, say, your sickle cell patient also has asthma or reactive airway disease on top of it. Monitoring your blood work. So again, your CBC diff for tick, monitoring that hemoglobin. Again, doing that nasopharyngeal swab if needed, and then a microplasma swab if you have a suspicion of mycoplasma. And then physiotherapy, again, super important having them involved not only for chest physio, but also incentive spirometry. So when it comes to transfusions for acute chest, you can give a simple blood transfusion of about 10 mils per kilo to help improve oxygen carrying capacity for patients who are symptomatic with acute chest and have a hemoglobin drop of about 10 grams per liter. For our patients who have hemoglobin SC and S beta plus thalassemia, they naturally have higher hemoglobin. So it's always good to consult with a sickle cell expert to see if transfusion would actually be helpful for them or not. For our severe cases of acute chest, for sure they would need an urgent exchange transfusion. So this would be in consultation with hematology, critical care, apheresis. This is really where there's a rapid progression of acute chest as manifested by an oxygen saturation below 90%, despite giving supplemental oxygen. They'll have an increase in respiratory distress, progressive pulmonary infiltrates on chest x-ray, and a decline in hemoglobin despite already giving simple blood transfusions. So this is just an example of how rapidly acute chest can progress. So on admission, that chest x-ray looks nice and clear. By 6 hours, you're seeing some changes to the left side. By 10 hours, you're seeing complete whiteout. And then 1 day after an exchange transfusion, you can see how much that exchange actually helped respiratory-wise, and that x-ray is much clearer. So stroke. Stroke is the most devastating neurological manifestation of sickle cell disease. We know that ischemic stroke can peak around the 2 to 5 year mark. Primary stroke incidence is about 7.8% by 14 years and 11% by 20 years. The reoccurrence is about 47 to 93% if a stroke is left untreated, and hemorrhagic strokes most often occur in the 20s. So I can honestly say for all of the babies that have been born through newborn screening, we haven't seen any of them have strokes. I would say the majority of the patients that we do see have strokes are new refugees, so patients who have come from areas that they probably haven't received proper care, or they've already come to us with a previous stroke. So if our patients present to the emergency department and a stroke the physician is thinking they might be having a stroke, we can initiate a stroke protocol, which involves hematology, ICU, neurology, neuroradiology, and diagnostic imaging. And so this is where they would get an urgent MRI of the brain, admission to ICU for that exchange transfusion. And really that exchange transfusion is, again, trying to get that hemoglobin S level down. The only way to prevent a secondary stroke from happening again is, again, to keep that S level down. So these patients would be put on a chronic transfusion program to help keep that hemoglobin S at least less than 30%. And so for our SS and S beta 0 thalassemia patients, we do something called transcranial Doppler screening, and that begins at age 2 years of age until about 16. And that's really just looking at how blood is flowing through the major blood vessels in the brain. We know the faster that blood is flowing or the higher the velocity, the more at risk those patients are for silent infarcts. So that's some of the common complications you might see for our patients presenting to hospital. But I just wanted to outline this pictorial because sickle cell disease is a multi-system, multi-organ disease. So there's many other areas of the body that can be affected that I actually haven't gone through today. And so some of the treatments that we have for for sickle cell patients, one of them is hydroxyurea. Hydroxyurea is a chemotherapy drug. It's been used in sickle cell disease since the 80s. It's actually the only disease modifying therapy we currently have in Canada for our patients. For us at Sick Kids, we follow the NIH guidelines for sickle cell disease, and this indicates that you can start hydroxyurea at 9 months of age. Hydroxyurea is meant to help stimulate the bone marrow into making hemoglobin F, or fetal hemoglobin. And the more fetal hemoglobin you can make, the less sickle. Less sickle means less complications. Hydroxyurea also tends to help preserve organ damage and reduce the natural inflammatory markers that you see with sickle cell disease. Some of the side effects of hydroxyurea is that it can lower some of your counts that help keep you safe from infection. So there is frequent blood work to monitor to make sure that our patients are safe on hydroxyurea. And hydroxyurea is just, it's not a cure. So for example, if a patient starts hydroxyurea because they've had frequent pain episodes, we know that hydroxyurea could take a good 3 to 6 months before it really starts to work. They can still continue to have pain episodes. And even for some of our patients that are well established on hydroxyurea, you're just hoping that if they do have that pain episode, it's a minor episode that they can maybe manage at home and avoid hospital admission. So this is just a pictorial of what it looks like when you're on hydroxyurea versus not. So the top picture is a patient who actually started on hydroxyurea. You can see that fetal hemoglobin going up and then down, but they eventually stopped taking the hydroxyurea to the point that they made no more fetal hemoglobin. Compared to the picture on the bottom, this patient is consistent with their hydroxyurea to the point that we got their fetal hemoglobin up to about 41%, which really only leaves about 59% sickle to cause problems. So other treatments, we do have bone marrow transplant at Sick Kids, but we only have sibling-related transplant. And so this is where you have to have a sibling of the same parents. We can do something called HLA matching of the siblings, or human leukogen antigen matching. The higher that match, the more successful transplants can be. So that's the only type of transplant we have right now at Sick Kids. Gene therapy is out there. So in the States, CRISPR was recently approved for sickle cell patients 12 years and older back in December. So CRISPR is where you're trying to alter the patient's genes to stop or treat disease. In the case of sickle cell disease, CRISPR is trying to increase the production of fetal hemoglobin. But right now we don't have that at Sick Kids. So in conclusion, sickle cell disease is an inherited blood disorder. The two main characteristics of sickle cell disease are longstanding anemia, recurrent episodes of vaso-occlusion. Pain, acute chest, splenic sequestration, and stroke are some of the major complications associated with sickle cell disease. It's super important to know and be aware of the Ontario Health Quality Statements. And really, awareness of treatment and assessment is key to providing optimal care. So I just want to highlight the clinical practice guidelines for sickle cell disease. So this can be found on the Sick Kids website, so www.sickkids.ca under clinical resources. And these are all the CPGs for sickle cell patients for any of the various reasons that they might be seen in hospital. So thank you for your time and attention. I'm happy to answer any questions.
There's nothing in the chat, but if you would like to unmute and ask a question, feel free to do so. I will stop the recording now.